College, this boy is my senior, so you can predict how old she is. Friends, ladies and gentlemen, first I'd like to express my sincere appreciation for having been accorded the honor of delivering this very auspicious speech to a distinguished audience which have come from 3 different countries in the world and representatives from other parts of the world on the occasion of the prestigious Malaysia-Singapore Congress of Medicine. I will speak on my mission to make the Ministry of Health the Ministry of Health, because there is this perception whether the Ministry of Health is a ministry which is committed towards health or towards treatment of diseases. That is why the topic is called Towards the Ministry of Health. And we find that many healthcare systems in the world, to varying degrees, are very disease-orientated, despite the concepts of new public health which have been around since the 1980s. We all understand that the goal of healthcare is very simply that of health. The means to achieve health include socio-economic changes, of course the role of medicine, and the vital role of very effective public health systems. Socio-economic conditions are important for the preservation and improvement of health and should surely enter in any broad scheme of healthcare. Health might best and not simply be defined as an individual's experience of well-being and integrity of mind and body. It is characterized by an acceptable absence of malady and consequently a person's ability to pursue his or her vital goals and to function fully in the context of the social and occupational world. Healthcare is an organized attempt to promote the health of its members, encompassing the fields of public health and medicine. The health policy is the organization of this method into some overall financial and distributional structures designed to pursue the general goals of healthcare and ultimately health. Modern medicine is challenged between the dual needs of the human desire to avoid illness, suffering, and death, and on the other hand, by the capacity of medicine as a combination of science and clinical skills to do something within the boundaries of its professional and competency and integrity to deal with such illness and suffering. The Alma Ata Declaration of the WHO in 1978 reaffirmed the WHO definition of health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. The Ministry of Health Malaysia considers health as a basic human right in accordance with the Constitution of the WHO. The enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being without distinction of race, religion, political belief, or economic or social condition. Thus, every Malaysian should be able to attain a level of health that will permit them to lead a socially and economically productive life as per the Alma Ata Declaration. The MAH also reaffirms its policy that health is a major resource that is critical to the success of the nation's economy. Health and healthcare are viewed as investments and not as a cost to this country. It is an accepted fact that the health status is determined by multiple variables, particularly genetics, the environment, the individual's lifestyle, and of course, the extent of the healthcare services which are available in a particular country. This is a more holistic concept of the idea of health. Thus, to attain good health, all these variable entities must be addressed, not only by the Ministry of Health, but also by other ministries whose policies and actions will have either a direct or indirect impact on health as a whole. Thus, the need for multi-sectoral collaboration, as well as good and effective collaboration between the public and private sectors to attain good health is essential. The government of Malaysia has farsightedly included health improvement as part of socio-economic development programs through its rolling 5-year Malaysian plans ever since independence in 1957. There is also reaffirmed by the WHO declaration that economic and social development is of basic importance to the fullest attainment of health for all. The promotion and protection of the health of the people is essential to sustained economic and social development and contributes to a better quality of life and to world peace. So they both are not mutually exclusive. So ladies and gentlemen, having that as a background, the emphasis of the Ministry of Health is slowly shifting from merely treating and managing diseases to the aspects of health and the maintenance of health. This means that we are training our science towards prevention and health promotion as well as healthy lifestyles and the promotion of a healthy environment. And in the next few minutes, I will illustrate to you how we are moving towards achieving that goal of being a ministry that promotes health rather than just treating and managing diseases. According to the Ottawa Charter, primary prevention involves preventing the onset of disease. It aims to reduce the incidence of disease. It involves the interventions that are applied before there is any evidence of disease or injury. Examples include protections against the effects of a disease agent as with vaccination. It also can include changes to behavior such as cigarette smoking or diet. The strategy is to remove causative risk factors which protects health, and so it is also part of the overall concept of health promotion. Primary prevention may be aimed at individuals or at whole communities. Individual approaches, for example, encouraging a young patient to stop smoking, has the advantage that the clinical's personal contact could be motivational, the message can be tailored to the patient, and we can expect support from him actually making the decisions to stop. But the limitation is that your advice does not tackle the underlying surrounding forces which are driving his behavior. In the first place, or the context in which his behavior occurs, like government policies and the environment which actually supports such a behavioral tendency. Therefore, a community or population-based approach using the mass media, using policies on taxations, and using policies to restrict smoking in certain areas have to be used to actually change the risk factor within the population as a whole. It is more radical, but it might produce the cultural, behavioral, and contextual changes which need to support the individual's choices. So examples for this kind of primary prevention, apart from smoking cessation, will also include preserving good nutritional status, creating an environment conducive for physical fitness, improving transportation, and ensuring good and healthy supply of water, as in many other things. These are the roles of health promotion and public health, and a successful primary prevention program requires that we know the risk factors and how we can actually modify. In approaching this noble intention of the preservation of the state of health, I will try within the confine of the time limit which is given to me today to highlight some examples in which we have actually got phenomenal successes and also some of the major challenges which you are facing in trying to achieve this process. I will use two examples to show how we have succeeded in Malaysia. One is the effectiveness of immunization in reducing the burden of disease and the success Malaysia has achieved in causing a phenomenal reduction in the number of patients with HIV. As I've said earlier, prevention is better than cure. The Ministry of Health has embarked onto a comprehensive program to eradicate vaccine preventable diseases. This is an entirely cost-effective way of attaining health rather than treating patients who have developed debilitating diseases later. In Malaysia, our vaccination program was started in 1950s. Even before independence, it was rather focused in certain urban areas. The National Immunization Program started in 1972 with 5 targeted vaccine-preventable diseases, namely TB, diphtheria, pertussis, tetanus, and polio. Later, many other vaccines were included in the national program. Measles vaccination was introduced in 1982. Since then, the incidence of measles has dropped dramatically, and whenever we see there are areas in which there's a resurgence, supplementary immunization is given, and presently we are working towards elimination of measles. A similar pattern is seen with neonatal tetanus. The incidence has been below 1 per 1,000 live births as recommended by WHO. Malaysia achieved maternal and neonatal tetanus elimination status in 1990 when the WHO announced the target goal during the World Summit for Children. Our human papilloma virus vaccination program, which is internationally accepted as an important effort to prevent cervical cancers, has been running smoothly and has achieved remarkable results. Since 2006, 99.5% of all female girls who enter Form 1 in our school system have been given the HPV vaccination. So this cohort from 2006, by statistical evidence, will have a 70% reduced chance of getting cervical cancer when they reach the risk-bearing age. These are some of the examples by which, through interventional programs like vaccination, we have managed to eliminate diseases, reduce diseases, and reduce the risk of getting other diseases over a period of time. Likewise, in the area of AIDS, since 1986, when HIV was first diagnosed in Malaysia, HIV has become one of the country's most feared public health and developmental problem. At the beginning of the epidemic, injecting drug users were a key factor that drove the country's responses, which focused more on creating awareness and early detection. The government, through the Ministry of Health, has embarked on a vigorous plan, program, and activity in tackling this disease in such a manner, ranging from primary, secondary, and tertiary prevention. Based on the country's strategic plans on AIDS, with vigorous interventions, we are aiming for the reduction of new HIV cases from 21.7 per 100,000 population in the year 2000 to 11 per 100,000 population in the year 2015. That is over a 5-year period. As a result, there has been a significant reduction of new cases by more than half, from 28.4 in 2002 to 11.42 per 100,000 population in 2013. And I'm very confident by 2015, we will be able to reach the target to reduce new HIV to 11 per 100,000 as per our intended objectives. As of 2013, Malaysia reported a cumulative 101,672 HIV cases, 20,235 AIDS cases, and 16,340 deaths relating to HIV and AIDS. The two interventions which actually caused this drastic reduction in the number of cases was the opiate substitution therapy and the syringe exchange program, which have become part and parcel of Malaysia's response for several years. Together, these programs are aimed at reaching out to at least 102,000, that is 60% persons out of an estimated population of 170,000 by 2015. Initiated in February 2006 and now entering its 6th year of operation, the syringe exchange program is mainly provided by NGOs, highlighting another incident in which collaboration between the public sector and the community is important in achieving health intervention, where 79% of all activities involving syringe exchange are conducted by NGOs, whilst 21% is also only conducted by the government-based clinics. As of 2013, this program reached out to nearly 72,686 intravenous drug users, with an average distribution of needle and syringe at about 522 per user per year. The other program is the methadone substitution or opiate substitution program, which was fully adopted in 2005, and as of 2013, this program is currently provided mainly by the government hospitals and with the support of primary healthcare practitioners, the National Drug Agency, and the prisons. And we have at present about 811 centers for opiate substitution therapy throughout the country, and this program has reached out to nearly 65,249 drug users nationwide. Through these reduction services, a total of 137,935, which is 79% of drug users, have benefited from either one of these programs. And these programs collectively have resulted in the very remarkable reduction in the number of HIV cases which we see in this country. Another achievement in HIV and AIDS prevention in this country is the prevention of HIV from mother to child. And moving towards eliminating mother-transmitted HIV, Malaysia has established a very high-quality intervention program since 1997, which is available in all government and some of the primary private healthcare facilities. And this program provides services which include screening, provision of antiretroviral therapy, care and support for pregnant women with HIV and their partners, and not only to mothers attending antenatal care, but also to those who miss antenatal care in the labor room itself. So through this, we have been able to cover a very large number of mothers, and by 2013, the number of those who were screened, which initially was 49%, reached nearly 100% by 2013. So these are the interventions which actually show how government's intervention programs towards reduction of diseases has been very, very successful, and we want to replicate similar models in the interventions and control of other diseases. And we are fortunate that in managing HIV and AIDS epidemic, financial resources is critical, that these activities run smoothly, and for the past several years, Malaysia has been among the few countries that are really committed in allocating adequate resources for this work, and this has been recognized in the Asia-Pacific region. We are proud that our government is funding approximately 95% of the total efforts in actually achieving this reduction, while the remaining 5% comes from funding from other sources. In general, the total expenditure has increased every year, and in 2013, the total expenditure was estimated at around 181 million ringgit. And we are also proud that we are one of the few